Good afternoon, everyone. Thank you for attending today's presentation on Rethinking Autologous Serum Tears in Clinical Practice by Dr. Matthew Ward. Dr. Ward is an ophthalmologist and cornea specialist practicing in Provo, Utah at the Riverwoods Eye Center. He completed medical school at the University of Utah and residency and cornea fellowship at the University of Iowa. He knows the Boston area, having also completed a fellowship at the Mass Eye and Ear Infirmary. He also completed a transitional internship at Newton-Wellesley Hospital. Dr. Ward has a robust ocular surface and dry eye practice. He is excited about new technologies that can solve clinical problems while decreasing healthcare costs. Today's webinar is sponsored by ArcPoint Labs and Asepticits. ArcPoint Labs is a leading nationwide provider of lab testing and wellness solutions for individuals and physicians. Our serum tears are produced using the PalaKit from Asepticits, a patented technology that enables our technicians to process the blood serum in a closed system sterile device that meets the highest aseptic standards. The PalaKit allows us to produce the tears on site, thus avoiding cost, delays, and stability issues that come with shipping. Asepticits is the designer and the developer of the PalaKit, the technology used in the making of the serum tears. The company's mission is to make serum tears available to all patients who need them by increasing access, convenience, and affordability. Before we start, a couple of housekeeping items today. Our meeting is recorded. Also, if you have questions, please enter them in the chat and we'll cover them at the end. With that, I'm pleased to hand off to Dr. Ward. Thank you.
Thank you, Matt. It's really a pleasure to be here and to be participating with your ArcPoint lab there in Boston. Boston is a place very close to my heart, and I've spent a couple of years of my life there and love that place. As you mentioned, I'm from Provo, Utah. Utah is the second driest state in the union, the driest being Nevada. So we have a lot of dry eye problems here, and the severity tends to be probably greater than average. This is a picture here not far from me, the Bonneville Salt Flats, and it doesn't get much more dry than that. I have a financial disclosure. TIFF LLC is the parent company of Asepticits, and I do have a financial interest there. And I will be talking about Asepticits products in this talk. This is my favorite way to start a dry eye discussion. Okay, my goal here is to make the audience cry because it's of the complexity of dry eye, and hopefully the induced lacrimation will help them see more clearly the rest of the presentation. But the bottom line is that dry eye disease is an extremely complex process that so much research and so much study has gone into elucidating the various origins of dry eye problems and various diagnostic and management technologies. The DEWS study, the Dry Eye Disease Workshop, in 2017 published a very comprehensive discussion of dry eye syndrome. And basically what dry eye disease comes down to is homeostasis. Okay, so as with anything in the body, for things to work properly, there has to be a balance. There has to be homeostasis. And in the tear film is no exception. If there's loss of homeostasis, then bad things happen, right? So your tears are trying to keep all the things, juggling all these peptides and molecules and trying to keep everything just right so we don't wind up with problems. The DEWS study really has a nice, concise definition of dry eye disease as a multifactorial loss of ocular surface homeostasis resulting in inflammation. The inflammation aspect is really critical to our modern understanding of dry eye disease, and it has not always been emphasized like it is now. The human tear film is incredibly complex. It has many roles. First of all, it has to be a very good lubricant, and to do that, it has a phospholipid external layer, which is evaporative protective layer. Deep to the lipid layer is the aqueous and mucin layers, which are kind of a complex. They hold the aqueous components down to the surface of the cornea. And the tear film provides nutrition and assists with metabolism. The anterior cornea provides all the oxygen to the cornea is diffused through the tear film. Glucose is in the tear film. It's important for good visual performance. If the tear film is not functioning properly, then vision is not good. Tear film assists with wound healing. There's growth factors in tear film, such as epidermal growth factor, TGF-beta, nerve growth factor. They're all important to helping corneal wounds heal and helping dry eyes heal. And then there's protective aspects. The tear film has innate immunity mechanisms through peptides such as lysozyme, lactoferrin, and IgA is present in large quantities in tear film to help prevent infection. It also has anti-inflammatory properties through various mediators. So what is the closest analog to human tears? When I was at University of Iowa, one of my cornea mentors was Michael Wagner. He happened to be the chief of cornea at Mass Eye and Ear for 10 years. And he would always teach us that when we were doing something called pterygium surgery, where we'd remove a growth from the conjunctiva, he said, well, what's the best thing to replace conjunctiva? Because there's other things you can use. You can use amniotic membrane and other things. He would always say, what better than conjunctiva? So the procedure I do when I remove a pterygium is I replace that removed conjunctiva with a conjunctival autograft. And that, in my opinion, is the best way to do it. So if you're trying to replace human tears, what's better to do it than human serum? If you have a lack of human tears, then human serum is the closest analog we have to human tears. What better way to restore homeostasis than a product that most closely approximates human tears? So this is a publication from 2015 that shows a comparison between tears and serum, and they're actually quite similar. In some cases, serum has higher quantities of beneficial things. In some cases, the tears do, but pH is the same, which is why they're so comfortable for patients to use. Osmolarity is the same. Epidermal and growth factor is slightly higher in serum. TGF-beta higher in serum. Vitamin A is higher in serum. So you go down this list, substance P, nerve growth factor are all present in human serum. So autologous serum has, just like tears, has anti-inflammatory properties, has epitheliotropic properties, which allow the epithelium to heal, neurotrophic properties, which help reinnervate the cornea and improve the nerve networks. Also contains phospholipids. Lipids are a prominent component of serum that are also there. So this DEWS study that I was talking about really attempts to take all aspects of dry eye and distill them into its most important aspects. And in this case, you start with the patient, you work through their symptoms, their various diagnoses, and then you try to arrive at a management plan. Pretty complex, as you can see. Well, sometimes I don't even like the word dry eye disease or dry eye syndrome. I'd say a majority of my patients, when I say, well, you've got dry eyes, I say that I've got what? They're not dry. In fact, they're tearing more often than I like. Or they'll say, sometimes they don't even burn. It's vision that bothers them the most. And so dry immediately introduces a sort of something that's not congruous with the patient's experience. So I like the term inflamed tear syndrome, but we'll use both interchangeably here. So my treatment approach, I sort of consider 4 groups of patients, and I'm most concerned about symptoms. There's, in my opinion, there's no reason if you see signs of dry eye and a patient has no problem, there's no reason to treat him. So if the symptoms are similar to the signs, meaning the patient comes in, they have burning, irritation, redness, and you look and there's punctate erosions and other epitheliopathy and maybe some meibomian gland dysfunction. Well, these are the patients I like to treat the most, and these are all written in order of expected therapeutic success. So symptoms equal signs, I expect to be successful in treatment. If signs are greater than symptoms, well, that means the patient's probably able to deal with more than the average person, but there's certainly signs there. And if they're having some symptoms, then I feel pretty confident I'll be able to achieve success. If the symptoms are greater than the signs, then I start to get a little bit worried. If I'm not really seeing why they're having a lot of symptoms, there may be other things like neuropathic pain pathways that have been activated. These can get to be a little bit more challenging to treat. And then if there's signs and no symptoms that I mentioned before, I usually don't go aggressively after these patients. I saw a lot of these at the VA when I was in training. I mean, a lot of these great vets that we have, they have a lot of signs on their eyes, but they just put up with a lot and don't get bothered by much. So my management approach, you can look anatomically at each of the things: the eyelids, meibomian glands, lacrimal glands, goblet cells, and there's various. They each have their own role, and they each have their own disease pathways. So I think it's important to look at all of the anatomy when considering a dry eye patient, because you may tailor your management based on the particular aspect of the anatomy that's gone wrong. But environment is also important. So as I mentioned, in Utah, we have a very dry environment. Humidity is low all the time, especially in the winter. A lot of my dry eye patients are coming in the winter with exacerbations. Allergens will worsen symptoms. Smoking is pro-inflammatory. So these are all things that, are important to take into account as well. So the DEWS study gives us kind of an outline of how we can approach management. I follow this pretty closely. I think they've done a very good job. And I would say, this is stage 1. So this is kind of the mild dry eye patient. This is the majority of patients, period, coming in my clinic. They'll have very mild dry eye disease, but they may have symptoms. So my techs know when I see them, I say, we're going to do dry eye basic, and that's kind of their cue to print off the proper things so the patients know what they're going to do. But first of all, I talk to them about modifying their environment. I write a prescription for them to move to Hawaii, which is almost universally successful, but very, very rarely followed. To eliminate or modify any offending topical or systemic medications where possible. This is not often possible, but if you can stop any medicines with anticholinergic properties, that's very helpful. Oral omega-3 supplementation is helpful. Using lipid-based artificial tears and hot compresses. So basically all conservative, over-the-counter things to help them in their mild condition. So I think that's very appropriate. Stage 2, and this is what the DEWS recommendation. This is where I think I've changed the way I think. But we'll talk about that later. But stage 2 is, I think, the majority of dry eye disease specific clinic visits. So not the majority of patients, but the most dry eye disease specific clinic visits are these patients, because they're usually much more. They've already failed stage 1 therapy. They're still having symptoms. So then, if we're not already on preservative-free tears, we may switch to those. We may do, and this is the DEWS recommendation, they may do some punctal occlusion, put some plugs in, and we might start to consider pharmacotherapy, either topically or systemically, T-cell inhibitors like Xiidra and cyclosporin A, corticosteroids, and oral doxycycline or azithromycin can be helpful. When we treat Demodex, we treat any eyelid disease, we might do tea tree oil, manual expression, do a lipoflow treatment or something like that. So we're starting to get a little bit more aggressive at stage 2. Now, stage 3 is where the DEWS will say, okay, well, nothing else is working. Let's start with serum tears, or consider serum tears, maybe some therapeutic contact lenses. And now there's some new therapies in the neurostimulation category where there's a device called TrueTears, which directly stimulates the cranial nerve 7 in the nose with an electrode that causes the lacrimal gland to secrete more tears. There's also pharmacologic stimulators like Trabaya, which is a cholinergic agonist, which has been shown to increase tear production. So there's some new treatments there. And then stage 4 is, per the DEWS, is long-term topical steroids, maybe amniotic membrane graft, which I'm not a big fan of in dry eye. I like it for other things, but it's, in my opinion, a very temporary Band-Aid for dry eye. Punctal cauterization, or in extreme cases, tarsorrhaphy. So this is the way I'm rethinking the DEWS recommendation. So stage 2, I now think that serum tears should be thought of as a stage 2 treatment, not stage 3. So certainly you can consider all the other things, punctal occlusion, switch to preservative-free tears. But I've now, in my practice, started to think first about serum tears before adding topical pharmacotherapy. I'll often will still do doxycycline or something like that, but I usually don't jump to cyclosporin or Xiidra first anymore. I'm starting to do tears, and I'll explain why. So why don't clinicians use serum tears? Well, they may be unacquainted with or unconvinced by the scientific basis. They may be unfamiliar with clinical applications. They may be afraid of the complexity of procurement, which traditionally has been very challenging. The cost of procurement has typically been very high, and patients may be unwilling. Maybe they think it's weird, or they don't like to get their blood drawn. Okay, so this old way of thinking is that serum tears are kind of obscure, they're kind of unusual, reserved for only severe and recalcitrant cases. They're an ace in the hole after everything else has been tried, and it's difficult to convince patients to even try it, and it's challenging to get them. So a clinician might think, well, why go to the effort of explaining something new, collecting payment, orchestrating blood collection and processing, when it's easiest just to write a prescription for a medication? Well, the procurement complexity is pretty significant, in the traditional view. You've got to have a phlebotomist draw the blood, centrifuge the blood. There's a sterile processing step, which is probably the most important link in the chain, and the most challenging link in the chain, because that's traditionally been done under a laminar flow hood, which are expensive. Then you have storage and transport. There's a cold chain. So if you're shipping things back and forth to keep them cold, and so the tears don't spoil, is a challenge, and all of that increased cost. So rethinking serum tears. So there's more and more data all the time supporting efficacy in a variety of things, not just dry eye disease, but a wide variety of conditions. Serum tears, I think, are more and more intuitive to patients, and procurement has been greatly simplified by aseptic kits and ARC Point, as I'll mention, and it's much more cost effective now. In my opinion, I actually consider it more effective than pharmacologic therapy. Now, there's never been, as far as I've been able to see, there's no head-to-head studies comparing serum tears to cyclosporin or Xiidra or these drugs. But just in my anecdotal clinical experience, they just work, and patients come back much more comfortable. If you prescribe Restasis and Xiidra for any amount of time, it's not, that's not fun. A large percent of your patients are coming back because of the cost. They don't want to pay it. You're getting calls from the pharmacy. Your front desk is dealing with that back and forth. You're writing pre-authorizations, and then half of the patients come back with burning, or they say they don't work, and so it's really a challenge. So why not use something that essentially functions like Restasis, Xiidra, and Oxervate in one, and achieve a better therapeutic impact with a lower cost? Is that how I view it now? So for patient adoption, I think culturally it's more intuitive in this day and age. We are free-range, organic, locally sourced society. The people want things that are natural with no preservatives. Okay, so intuitively people want things that are natural versus artificial, and that's serum tears versus commercially made medication and lubricants. There's really wide application. So not only stage 2 dry eye disease and beyond, but neurotrophic keratopathy, persistent epithelial defects, exposure keratopathy, and I'll use it in patients that are going to go to surgery, pre and post surgery. So now let me just give you a little overview of how I've seen clinicians and myself look at being able to get serum tears. There are some, from a local standpoint, there are some compounding pharmacies that do this. Now, if you are an ophthalmologist, you know that compounding pharmacies, the small local ones, are becoming extinct faster than the black-footed ferret. So you've got, these are few and far between, but there are a few that will do it, and those clinicians probably, have a good system that works for them there. But There's not that many of them left. Lion's eye banks will do this. There's not that many of these either. And from my experience, this is what I did before I started using aseptic kits. I would have my patient use the Utah Lion's Eye Bank, but that essentially functioned like a national lab. They had to ship things, even though it was 40 miles away, they still had to ship things via FedEx and in a cold bag and everything back and forth, which is what the national companies do, and it's expensive. So now the other local option, and this is sort of local and national because aseptic kits can be used in people's clinics. We don't have an arc point in my area in Utah, so I do this now in my office. But where there is an arc point, it can be done. It can be written as a prescription and be done locally that way. And it's greatly simplified the process, and it's much cheaper and much less time. Nationally, there's a company called Vital Tears, which has done a good job of making this available to basically anybody in the country. But it's expensive, and there's quite a long turnaround, 48 hours or more. And then there's cold chain problems that I mentioned. So aseptic kits and arc point, this is a local solution, as I mentioned. It's convenient, cost-effective, with a fast turnaround. I don't know, Matt, how quickly you can turn these around in your lab. How long do patients wait typically?
If they're coming in the morning, they'll have them early afternoon. So typically it takes us about 2 hours to do the blood draw and the processing.
Yeah.
So very quick.
That's great. Yeah, I mean, that's my experience too. And I have an urgent care downstairs that draws the blood, and then my assistants prepare it. It takes about 2 to 3 hours. The patient either waits and goes home, or they'll get their blood drawn and go run an errand, and then they'll come and pick them up. It utilizes a patented kit-based sterile preparation methodology, which is invented and pioneered by aseptic kits, which in my opinion is truly a disruptive technology in the way that we look at sterile preparations in general, not just serum tears. But it's a closed system that is in contrast to laminar flow hoods. It's technique independent, also in contrast to laminar flow hoods, and provides maximum sterility assurance. In brief, the aseptic kits technology utilizes a pre-sterilized plastic bag where all the components needed to fill and cap the bottles are inside the bag and pre-sterilized, and all the capping can occur external to the bag, so there's no contamination of the internal contents. The bag is coupled using a patented method to a 0.2 micron filter. So any fluid passing through that into that bag is sterilized as it goes through the bag. And so it's really, really ingenious the way they've come up with this. So I consider this a clean room in a bag, and there's no laminar flow hood needed. It really meets or exceeds USP 797 guidelines from our reading of it for ophthalmic sterile preparations. It can be used anytime and anywhere. No need for an expensive facility. So let's look at cost. And this is based on a 4 times a day use of serum tears. So local compounding pharmacies are variable. I've seen some that are pretty inexpensive, like $200 or $300 for maybe 6 months. But again, those are hard to find. Eye banks tend to be expensive, $600 or more for 6 months. National processing centers like Vital Tears, I mentioned, $660 for 6 months. With aseptic kits or arc point, I know Matt said that for 6 months that he's using, they're able to make about a 6 month supply for $439, which is 30 to 40% savings over Vital Tears or other options. And if you're looking at it compared to other treatment modalities, it's not even close. Preservative-free artificial tears, of course, this depends on how often patients are using them, but they may cost up to $500 a year. And on the low end, depending on where you're getting the serum tears, you might get a year's supply for $500 to $600 of serum tears. So that's where I'm kind of like, why make them do the preservative-free tears for so often if serum tears are better and not actually that much more expensive? You can see all the pharmaceuticals are just outlandishly expensive. $3,500 for Restasis, $3,800 for Xiidra, $3,600 for the new Trevia, and $88,000 for Oxervate. So for someone that has neurotrophic disease in the cornea or neurotrophic ulcer, I think it's almost a crime against our society not to try serum tears, at least for as long as they seem to be clinically responding. I mean, why subject our society to $88,000 in costs for an eight-week treatment? I've used Oxervate. It works. I really liked it when I need it, but I think I would definitely first try serum tears. And then a bilateral treatment with LipiFlow is $1,600. So I really think when you look at serum tears this way, you can see, this is, to me, it's a no-brainer why it shouldn't be considered much earlier in our management of these conditions. So in conclusion, dry disease is a complex, multifactorial condition resulting from loss of ocular surface homeostasis. Serum tears are an effective treatment that can and should be considered for patients much earlier than traditionally thought, in my opinion. The aseptic kits technology has greatly simplified the procurement of serum tears at a reduced cost, enabling us to rethink the role of serum tears in our clinical practice. And ArcPoint Labs is an excellent local source where aseptic kits technology can be applied for patients to benefit from serum tears in a convenient, cost-effective manner. Thank you very much. This is my family a couple of years ago at the Boston Public Gardens. So.
Thank you, Dr. Ward. There were some questions in the chat that I entered. Are you able to see them on your end, or do you want me to read them for you?
Let's see. I think I can. Let me open that up. Yeah. So can I discuss how well tolerated serum tears are for patients? I mean, I don't want to oversell serum tears. I'm not trying to say it's perfect for everything. It's certainly treatment of dry eye disease is just as multifactorial as the causes, but I just never have someone come back saying that they didn't tolerate them, that they were uncomfortable. I don't think I've ever had that. Whereas it's so different with the pharmacologic therapies. I've even had a couple weeks ago, a patient came back and used the word heavenly. I'm not just saying that, she said, these are heavenly. And it was the first time that she had had relief. And so they're very well tolerated. That's one reason I love using them, because I know they may come back and say they don't work or they're not helpful, but I rarely have them come back saying that they're uncomfortable in any way. One kit, this is from Tim, one kit suggested retail was $275 to $300. Does anyone know how many months supply that covers? Okay. Well, I'm not sure which.
Gail was indicating 6 months. I think it's a function of whether the patient is ordering the 40 ml versus the 60 ml. And then the dosage and frequency. So
for your lab.
Mm-hmm.
Yeah, so that's right. So I did notice that on your website. So for 40 mLs, it's a lower price, and probably more like a 3 to 4 month supply. But I mean, most of the time, if you're doing a 20% concentration, most of the time you can get 60 mLs, which correlates to 12 5 milliliter bottles, and that it obviously depends on dosing, but a QID dosing that should last 5 to 6 months. Patients are using it more frequently, it may not last quite as long, but yeah. And then another question, can you describe any complications from the use of serum tears? I mean, short of maybe the blood draw, maybe the bruising at the blood draw site or things, I really can't. I don't know. As I mentioned, there's immunoglobulins in serum. If anything, they probably have some antimicrobial effect. There's glucose in serum as well, so I guess you could say, and there's some discussion in the literature as well. If you draw blood from someone with a systemic inflammatory disease like rheumatoid arthritis or something else, and you draw their serum, it's a theoretical question, but is there a higher degree of of inflammatory molecules in that serum that could potentiate inflammation on the ocular surface. I don't know of any data or any study that suggested that's actually the case, but it's just been brought up as a potential concern. I've never seen that, and I've used serum tears in a lot of patients with rheumatoid. In fact, traditionally, that's what I used to do. I mean, I still do it, but now I use it more than I used to, of course. But traditionally, that's kind of the patient I would choose first. It would be the bad Sjogren's patient or the rheumatoid patient that's not getting relief otherwise, and I just really haven't seen that be a problem. And so, and then one last question, is there a situation where there's contraindication to using serum tears? And yeah, I mean, I think if you, certainly that's partly clinical judgment. I mean, sometimes a disease process can be so far down the line that there's other things you need to be doing or thinking about than just doing serum tears. But, you know, there's other uses of serum tears. There's allogeneic serum tears where you're drawing blood from someone else and using that blood product on someone that has a difficult blood draw or can't get their blood drawn for one reason or other. There's good studies showing that that's effective. But those kinds of things, I would say it's contraindicated unless you do proper testing, you know, on that allogeneic serum. But I really don't see any reason that serum couldn't be tried. I mean, it's almost as benign from that standpoint, in my opinion, as artificial tears. I mean, you know, the worst thing that can happen is they just don't work. But I think that's a much lower percentage in serum tears than it is with artificial tears.
Looks like we've got a couple of questions that I think are very much related about lab testing.
Okay. Oh yeah, do you order blood tests for such conditions as rheumatoid? Yeah, our blood test determines serotonin treatment. I sometimes do. So I always, when I work up a dry eye patient, I'll for sure, you know, I like to get to the bottom of what's really causing their dry eye. So it's, like I said, it's almost always multifactorial, but if they seem to have a low Schirmer score, they're not making a lot of tears, the staining, their fluorescein staining pattern is very central or especially severe. Those are all hints in my mind that this could be related to a systemic inflammatory disease. And so I will send labs for all of those, the RF, ANA, SSA, SSB, all of those to try and detect if there's an underlying systemic disease. That's not only helpful to know in terms of their dry eye treatment, but if it's previously undiagnosed, then I'll refer them to a rheumatologist because that can be a benefit to them systemically. So that's very important. I don't order them necessarily as a rule, as a screening process if I'm doing serum tears or something. Whether I order those or not is just based on my clinical judgment of the patient's particular case. And so.
I think we're at the end of our questions. Unless we have any other questions coming into the chat, I think that concludes our webinar. I'd like to take this moment to thank Dr. Ward for his time today and all of the effort that he put into preparing the presentation. Very valuable and informative. I'd also like to thank everyone who was able to join the call. It looks like we do have a couple more chats coming in, so if you can stay with us a minute longer, Dr. Ward, maybe we can cover those. Oh, looks like it was an exclamation. Two thank yous. So no more questions, but two heartfelt thank yous for you, Dr. Ward.
Thank you. No, thank you for letting me do this, and hopefully you find more success in your dry eye practices with using serum tears with a greater role.
Great. Well, thanks again for your participation, and we look forward to working with you in the future.
Thank you.
Bye-bye.